Boing, boing. Boing, boing.
10 participants. Si class iko kweli? Yes, Daddy.
I did it.
You did it. Hebu nikugulie.
I'm really so addicted to you. I also used to sketch up. I'm the one who's addicted. I wish I could express myself.
Engagement announcements. Name a Connus. Connus? Come on, Carl. The kid wouldn't change his name.
You're right.
Don't you amazing, forget just the way you as your rock on burns. Will you call my name? As your rock on burns. Will you call my name?
No problem. Once you've done it.
In progress.
Yes, sir. Yeah. Oh, in that one. Oh, that is easy. Yes, I want to part of the test. Hello? Hello? Hi, ma'am. Ma'am. How are you doing? Hello? If you pay a deal, yeah, you can't come as you used to pay. Just somebody in a car. Oh, for that. Oh, okay. And this is that's your said, I come to okay. Now, you know, to me, all my now, when I there's a busy place party. Oh, go come away, what cheaper? Eh? What? Does it have a real name? Nikki, what? And then what did they come? Does it have a name that everyone can do? Oh, but we don't come. I can't do any for that. I can't do make it out. Okay, they go. Hello? Kaidi? Na mwidike mindo ndropis ni mwike mauta. Yeah, first you gel, yes, but then cow salts, I've never had anything about that. Yeah, first you gel, but then the cow salts, I'll check on the internet about it. I'm fine. I've just come from showering with because now apparently there's some people with corona in our ward, so I have to shower when they come home. Yeah, exactly. Okay. You want to talk? So can I talk to Perez? Good night, Mom. I love you. Imagine the person with us. How would you then? Hello? 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 Hello?
Hello, Titi. Hello. Oh, sikiza niwe nimbeleze. Sasa ni gavana. Okay, ngoja.
Hello, Perez. I've missed you so much, my love. Even you, unanidanganya. Mimi nimekumiss explanation. Hata nilikuwa na yako sana. I promise jana nilikuwa na date yako na leo nilikuwa na kuangalia alafu umenipigia. That means that God is teaching you to me. That means I love you so much. So unafanya nini? Uko class 4? Unafanya nini class 4? Unafanya long division? Ni ngumu. Unapata 100%. Unapata 100%. But unakuja wewe.
Hello. Yes, honey. How are you? Leo nimeshinda niking'ang'ana na watu wa nyumba na huko nikisema nikupe, yani leo it was just a chaotic day. Nakuja ilikuwa inaniuma, nikaenda hata kwa saluni nikaenda ikatolewa. Ilikuwa kwa saluni last week on Thursday. Sasa hiyo kuja hakutoa vizuri, akampakisha kidogo ilikuwa inanifunga kwa nyumba. I told him, yes. Mimi bro ni mbaya. We. Sindio? Yes. Na ukikanyanga chini unasikia kama unadungwa na nini na shindano. Hey, how is mom? Tomorrow is Friday. Ngoja nione. Okay, what the fuck? Yeah. Oh.
Ndio hiyo.
Also dresses. Sort of the home they want. Ile t-shirt ya Jobim. Sikuenda nayo. T-shirt ulisema ni kubwa uitaki. Sisi kwanza ndo unavaa binshaga kid. Ingine kuvaa. Niko?
Mimi niko na nini? Niko na kitu nafanya asubuhi. Sasa nikisema ni kwanza kwenda ni huku masaa 7, unaelewa? Na nakwambia nimefunga nyumba huko mambo ya huko nyara nimefungiwa tena. Sasa na wajalipa mpaka saa hii. Sasa sijui vile kutaenda asubuhi. Nitauliza lawyer yangu, yani niko na hiyo issue kesho. I wish tungesema kama Tuesday. Tuesday next week. Inaanza Tuesday na Friday. Hatuwezi kukaa mpaka Tuesday, tunajua Saturday hawezi kukaa. Na uko na watoto wawili na uko Afrika, kila kitu ni cash. So what I'm wondering, hapa katikati niongelesha hadi watoto.
For whom? For what you say? For who?
Record. Oh,
Look at Sugar.
so I was saying, I apologize for the delay. It's been quite a hectic day with exams and everything, but I'm glad that you are able to hold on, and I hope it's worth your while for us to have this talk on dementia. So this is just an artist's impression of what dementia might look like, because it's really at the base of it an issue with memory. And the guy is saying, I remember the face, but I've forgotten your name, which is very common with people with dementia, that somehow something looks familiar, but you can't place it. You can't quite find the name. And this is usually early, very early on in the dementia. Later, even just looking at a picture like that, you'll not even be able to tell whether you're looking at another human being or an animal, or, you know, it's not even possible cognitively to tell. So dementia is a brain disease, and it is not part of normal aging, because a lot of people think that that you are aging, so it's okay to forget stuff and so on. And it has to be distinguished from the normal senile dementia that happens when we get to certain ages beyond. It's like the brain has aged faster than it would ordinarily do, and so it leads to these cognitive deficits. Initially, things like forgetting names, misplacing keys, getting lost in familiar places. And there could be an underlying medical condition. So dementia refers to a group of symptoms, including memory loss and loss of independent function. And that's why there's a mushrooming of institutions that are referred to assisted living, that these individuals have lost independent functioning and have to be assisted. This is a rapidly growing line of business in in psychological health. It's also recognized that, like I mentioned before, it's not part of normal aging, but it's due to brain disease, where there is a degeneration of specific brain regions. And of course, then depending on where the degeneration is most prominent, then the dementia will take a certain quality or a certain presentation that is typical of the functions of that part of the brain. Mental capacity declines progressively along with a reduction in their ability to function normally. And this we are talking about activities of daily living, showering, dressing, feeding, sphincter control, social interactions and social graces, all seem to start to decline as the dementia sets in. It has an insidious onset and the early signs, and the patients usually are unable to pinpoint exactly when the symptoms first appear, and they are equally baffled by the fact that they are unable to remember and execute things that used to come to them as second nature. Now they are struggling and needing help from significant others. How common is dementia? It's estimated more than 20, probably 30 million people worldwide have dementia. And by 2040, it has been projected to hit the 80+ million people. You know, 1 in every 1,000 aged between 40 and 65 will develop dementia, and 1 out of 5 or 20% of all individuals above the age of 80 will have dementia. In the US, it is believed that African Americans are twice as likely to develop dementia than Caucasian. That can basically be explained by lifestyle, because early deterioration of brain functions is also associated with poor lifestyle, with poor lifestyles. You know, lack of dietary concern and control, lack of exercise, poor control of things like hypertension, diabetes, cholesterol. All these can and do contribute to the development of dementia at a fairly early age. Hispanics are half times more likely to be stricken with it. So in order, you have the African Americans, then the Hispanics, and then the Caucasians. And this is the progression and development of dementia over the years. And you realize that as you become more industrialized and more developed, so to speak, so do the rates of dementia go up. And a lot of it has to do with lifestyle, the diet, and so on. I mean, in the 1900s, if you lived in Africa, you were probably just emerging from the caves. You are a hunter-gatherer. You only ate when the food became available, and certainly it was not enriched. It was not the kind of food that you eat. You had to run and catch your own prey. You had to dig for roots and things. You had to fend for yourself. You're a hunter and a gatherer. But you can see that the rate of dementia has steadily risen as the process of availability of food and ease of finding food has gotten better. Who is most likely to develop dementia? Well, age seems to be a risk factor. So the elderly people, usually over the age of 65. Before the age of 65, there was that broad classification that you either had a pre-senile dementia, you are before 65, when you are 65 above, it would be referred to as senile, but then senile, there are different types of dementias therein. Some people do seem to have a genetic predisposition. You find that in certain families, individuals develop dementia at a much earlier age than others. Of course, the basic pathology, the lifestyle, smoking, drinking, food, lack of exercise, etc. All of it boils down to, excuse me, to the loss of brain cell, neuronal loss, basically. That's the bottom line, that we are ending up in a situation where the number of brain cells or neurons is dropping at a fairly rapid rate. People with Down syndrome seem to also to have a predisposition to dementia. They seem to develop a brain damage. And if you look at pathology within the brains of individuals with Down syndromes who develop dementia, it mirrors the kind of brain pathology that we see with Alzheimer's. People with atherosclerosis, through compromising of the diameter of the lumen of most of the small blood vessels in the brain, and that basically means that at some point they block and kill off brain cells beyond the blood supply that the necessary arteries would have. So there are different types of dementia. Cortical dementia, basically loss of the brain cells in the cortex, and then subcortical dementia, and then there's progressive, primary, and secondary. We talk of damage to the brain that affects the cortex of the brain or the outer layer as the cortical, and the patient is likely to present with problems with memory, with language. Usually, typically, it will be short-term, immediate and short-term memory before you get to the more long-term memory. So typically, these individuals will want to talk about, they're more at ease and happier discussing their childhood than events that have occurred in the last month, 2 months, and so on. Language, use of language, struggling finding words, odd use of language, thinking, getting muddled up, not finding it difficult to engage in abstract thinking, loss of social graces, social behavior, these are executive functions. When you are at a table, wash your hands, wait your turn, use the fork and knife, don't use your hands, and things like that. The subcortical affects the brain below the cortex. Most of the times, the changes will look like emotional dysregulation and movement disorders, changes in gait, changes in fine motor control and coordination will and do present with in subcortical dementia. Progressive dementia, well, all dementias are basically progressive, and that's just a descriptive term to say that with the time the dementia gets worse, and indeed with the passage of time there's an exponential rise in the loss of function. Primary dementia, that there is a disease like in Alzheimer's, and the pathology can be demonstrated, and there is no other cause or related disease process. Then there is secondary dementia, which is self-explanatory. Maybe a person has been a boxer, or was involved in contact sports, or had suffered a head injury, or developed a stroke and killed off parts of the brain, and the dementia, of course, will set in much earlier. Then there are the disorders that mimic dementia. So this would be referred to as pseudo dementia, where, for example, there is mental retardation. The individual did not start off with a normal brain that then deteriorated to be demented, but they basically started off as having mental retardation, and in the process they might appear as if they have dementia. Or there could be a personality issue. Sometimes when people suffer from things like seizures, in an intra-ictal or post-ictal or inter-ictal state, they might appear to have dementia. Sundowners, this is basically a situation that appears to occur with in patients with delirium, where in the evenings, because of the sleep-wake cycle, in the evenings, the confusion seems to increase, and therefore their memory deteriorates around that time, and only gets better during the day. And some of the things that may cause delirium, of course, we know are fever, intoxications, and other disorders, other causes of delirium, basically. Alzheimer's and dementia. Alzheimer's, of course, is the most common cause of dementia, accounting for more than 70% of individuals who present with dementia. They will have a severe mental deterioration. It occurs in old age. They will have loss of memory and control of other bodily functions, and these are the so-called activities of daily living. And it deteriorates, and like I hinted earlier, it is an exponential deterioration in cognitive functions that will typify this kind of dementia. It is also known to cause a lot of deaths. In the US, over 100,000 deaths per year can be directly related to Alzheimer's. It is the fourth leading cause of death in senior adults. It's also a very, very expensive condition, draining, at least by the time this paper was coming out, about $100 billion a year is spent on Alzheimer-related situations. So far, nobody knows how to treat dementia. There are a lot of experimental drugs out there. In my view, a total waste of good money. Nobody, and I repeat, nobody knows how to treat dementia. You can only manage it, and most of the management is directed towards trying to slow down the progression. So identifying the risk factors, clamping down on them early, very early, to try and stem and preserve cognitive functions for as long as possible, is the mainstay of management of dementia. These are the conditions that can contribute to dementia. Medications can look like, reactions to medications can look like dementia symptoms. Some of the medications, when you take them, they interfere with cognitive functions and can appear and look like dementia. Nutritional deficiencies, particularly the B vitamins, are known to present, are known to present or to worsen dementia. Infections of the brain, meningitis, leading to confusion and delirium, or what might appear as a sudden and severe dementia, with the usual features of dementia, but usually reversible if you treat these conditions early enough. Heavy metal poisoning, lead, for example, can and do cause symptoms of dementia. Damage, brain tumors, like I alluded to, cerebrovascular accidents, head injuries, all these can and do cause progression of and worsening of dementia. The symptoms of dementia, needless to say, start with memory loss. And like I say, the more recent memories are the ones that are the earliest to be lost. And then with the passage of time, longer term memories also get lost to a point that the individual completely has absolutely no memory of anything. Personality changes also occur, like I said, executive functions that define you as a human being, that give you that finesse, knowing when to talk, when to laugh, how to eat, cover your mouth, use the fork, don't use your hands, don't talk with food in your mouth, catastrophic reactions like something very small happens, the individual overreacts, and then disorientation, getting lost in familiar places, not knowing where you are or who are the people around you, or what day is it, what date is it, what year is it. These are all things that that occur. Mood changes quickly and easily, and that's what I'm calling a catastrophic reaction. That they may respond to emotive situations in a very unpredictable and sometimes bizarre manner. Changes in sleep as well. You'll notice that a person with dementia may spend the whole night just pacing up and down, looking for God knows what. There are titles or there are papers about something that they are afraid that somebody may be interested in. So trouble falling asleep, staying asleep, a reversal of the sleep patterns is just like occurs in delirium. But there is a sleep-wake cycle reversal. The person might want to sleep by day and be active by night. And you can see they are restless, annoyed, confused at the end of the day. This is the sundowning that we are talking about. Towards the end of the evening and in the early parts of the night, there is more restlessness, mood dysregulation, and confusion. So sleeping all day and awake all night the sleep-wake cycle reversal. Now, obviously, something is happening at the brain. Dementia causes the brain to be smaller, and it is known that also dementia is a result of a reduction in blood and oxygen to the brain cells. For whatever reason, whatever pathology compromises blood and oxygen supply to the brain will and does lead to dementia. We've talked about the short-term memory being the first to go, and of course, the rapid deterioration with the passage of time. This is just a scan to illustrate the kind of difference between what you'd refer to as a normal brain and a brain that is afflicted by Alzheimer's disease, and the various percentages of cortical gray matter loss represented in those pictures. And of course, the Alzheimer one is quite dramatic. These are the various parts of the brain, and of course, the more symptoms you have of a particular part of the brain, the more likely the more likely and the more significant would be the loss in brain cells in those particular areas of the brain. So this one is saying senile dementia is not so bad, Ms. DuPont. It's kind of like having brand new friends every day. Yeah, so you absolutely have no recollection of who you met yesterday. So every person you meet is new and is a friend. This is a representation of the various presentations of dementia. Loss of memory, forgetting names, appointments, misplacing keys, being repetitive because you can't remember what you said. The disorientation to place, time, translates into, getting lost in shopping malls, in getting lost in places that were familiar in the past, but now it's as if they are new places and the person can't make their way around them. Even in the village where a person may have lived, sometimes the relatives come and say, I cannot leave this person in the house alone, because as soon as they step out of the door and out of the gate, then they are lost. We can't find them. We have to send search parties to look for them. And many a time, these people get lost and get lost forever. And either will be discovered in mortuaries or in police stations or in hospital facilities as unknown African male or female. Impaired judgment, difficulty to manage finances, making unwise or even dangerous decisions. And this also, of course, causes individuals to have to seek. Family members may come to you and say, our person is making very unwise and very very injudicious decisions regarding finances, regarding property, or even people who are close to them who know the individual has no memory, may be taking advantage of them. So sometimes as doctors, we have to make recommendations that the individual be assisted with a family member or close family member to help them manage their affairs. And this has to go to a court, and then the court has to make a ruling and appoint and decide which family members would then be given that responsibility. Language difficulties, not remembering meanings of words, difficulty in naming common objects. Yeah, you know, things that you know, this is a baton, this is a pen, this is a shirt, this is a knife. This person may say this thing that we use for this thing, you see. They are not able to actually find the words. Grammatical errors, the person would speak very good English or Swahili or even their mother tongue, and now the language is distorted. Change in behavior, in mood and behavior, having hallucinations, holding delusions, false beliefs, hiding belongings because they are deluded and paranoid, being suspicious, agitated, restless, or anxious. These are what would be referred to as release symptoms, frontal lobe release symptoms. The executive functions are lost. The inhibitory property of the frontal lobe on the rest of the brain has been lifted. And so this breakthrough, and you get this kind of symptoms. Difficulties in performing tasks, organizing events like dinners, holidays. One patient of mine said, I used to entertain so much. Now it is I have to get help if I want to have visitors in my house. Not knowing how to cook or maintain cleanliness, things which used to come as second nature now are quite a challenge. Making work-related errors, missing deadlines, inability to cope with workloads, being unable to learn new skills. So difficulties in performing tasks is another major presentation. Now, a diagnosis, the person will go to see a neurologist. The doctor needs to know why the person has come, the symptoms, and when they started, and if there's been any progression, and if there is, how much progression. That's sort of this, you know, the normal history taking. Doesn't even have to be a neurologist. It could be just you as the doctor taking a good history, know the knowledge of the normal progression of dementia and the associated risk factors will usually help in arriving at the presence of certain physical indicators like high blood pressure, fever. All these could be pointers at what might be physical exam, reflexes, sensations, coordination, very important, senses, language skills, like we say, balancing, even walking, may all be affected from a physical perspective. So when we suspect that it is dementia, we may want to do imaging. We might do laboratory testing to see if there are any other causes of dementia that may not be so obvious, like syphilis, HIV infection. AIDS dementia is a well-known complication of HIV infection. General paralysis of the insane with psychosis, as a complication of tertiary syphilis, renal failure, and so on and so forth. So imaging, you might see typical features, and of course, all the other add-ons in terms of testing can be done. Diagnosing and treating dementia, of course, dementia is a major healthcare concern, and often it will have been noticed by others rather than the patient themselves, and so it will be significant others who bring the patient forward for assessment cognitive testing, memory questionnaires, neuropsychological testing, and imaging are all very important in arriving at the diagnosis. Like we've said, a lot of the dementias are lifestyle diseases, so lifestyle choices may play a significant role in preventing or delaying, and I note that very carefully, in delaying the onset of dementia. So these are some of the things one could do. Challenge your brain. Provide your brain with the regular challenges, regular mental exercises, learn new skills such as a language, pick up a musical instrument. Look at the diet, yeah? Consider adopting a Mediterranean type diet, plenty of fish, green leafy vegetables, grains, and small portions of nuts, small portions of fruit, olive oil, and moderate amounts of red wine. We are not advocating for alcohol, just moderate, small amounts. And if you look at the daily allowable amounts of alcohol, that will give you a rough guide as to how much alcohol one is allowed. Workout, which is exercise, and we are referring here to a cardio workout, a minimum of 3 times a week, or at least 30 minutes each time. The more, the better. So maintain good physical health, exercise, walking, swimming, weights, yoga, tai chi. The aim being really to just increase the blood flow to the brain, lower blood pressure, make your lungs and heart stronger. Yes, so that you can fight off depression as well. Muscle mass increases strength and metabolism, which helps with weight, blood sugar, and of course the flexibility that comes with it. It is also a very difficult job for caregivers of people with dementia. It's overwhelming, frustrating, very emotional. Many a time we have to depend on family members, especially in the typical African society. We hardly take our people to old folks' home. Remember, I talked about assisted living arrangements. We hardly have people taking their age. They just look at them in the village. You assign them somebody to feed them, to wash them, and to take them for walks and things like that. But it can be overwhelming. If you're a large family, rotating the responsibility amongst the different siblings could be a very good strategy for managing the care of a person with dementia. These are the things that they may need help with. In my last slide, feeding, and it increasingly becomes more and more difficult to feed these individuals. I have seen patients requiring to get a peg their stomachs to just help with feeding because they no longer recognize the food. You can hardly get them to open their mouths, and you don't want them to go home with an NG tube. So a peg may be placed there just to assist with feeding. Dressing, again, helping an individual dress who doesn't care whether they are naked or not. Washing and bathing and personal hygiene, use of things like diapers and so on. The moving and handling and supervising are another very important aspect of their care. Their mobility, ensuring that their joints do not freeze in one place, ensuring that they are moving, they are getting the physiotherapy and exercise. Being careful with safety in the home. Remember, these persons have regressed almost into a childlike state. So they may not recognize dangerous situations and pieces of equipment in the house. And so paying attention to their safety is another very important aspect. Telecare technology, not so common here, but use of AI, robots and things like that can also improve the care of these individuals. Advanced care planning, in other words, being able to anticipate getting this person to do their will when they still have it together, getting their affairs organized and put in order, planning for their care, like in an old folks home, quite early, knowing that you probably will end up having to take them there for you to be able to even work and provide for them. So advanced care planning, very, very important. So I'm going to stop there and just open it up for discussion. Thank you very much. Any comments, questions? Obviously, this is really a very brief summary. We would I would expect you to read around the subject a little bit more.
Dr. Kigamwa, okay, there's a question in the chat box. Are you able to access the chat box? Doc?
Sorry about that. Yeah, so the question says, isn't the data on increasing rates of dementia skewed by the fact that we have higher life expectancy in the modern era and therefore more old people, or are the cases of senile dementia excluded in calculating the rate? I would say yes and no. The senile dementia, basically people accept that it will always be there and all of us eventually get demented. But the rate at which we are getting people ending up with dementia has a lot to do with lifestyle. And that you will notice if you were to profile the individuals who develop these types of dementia, they've had a certain lifestyle. And then if you look at those individuals who do not develop dementia until quite late in their lives, again, there will be a difference in their lifestyles. So yes, it could be skewed. We are living longer, but at the same time, lifestyle seems to be a very, very significant aspect of the early development of dementia. I think that was the only question there.
All right, Doc, I think
Done. Okay, well, thank you very much. My apologies again for keeping you up to this hour in the night, but I appreciate your patience and wanting to participate. Thank you very much. I wish you a good evening. Thank you.
Is it? Yes.